psychological distress prevalence ranges from 25.57 to 44.6 globally, while in our countries, different studies or different empirical studies just show this with the range of prevalence from 9.2 to 34.6. So this number is not low because this is just increasing in different population groups and with different social backgrounds. So what we know, or what contributes to this PD, are including the type of diabetes. Of course, we know there are 6 types of diabetes currently, and the duration with diabetes can also affect, as well as the presence of complications related to diabetes. Of course, there are short-term and long-term complications that can also include. So Alzheimer's disease can be related with that. Dementia and vascular dementia are just related with diabetes, and also treatment burden complexity. Due to that, quality of life and the stress and anxiety are paramount among this population, and there is a limited social support. Different studies report that social support is one of the treatment factors that can alleviate the burden with mental and other complications among this population. And also the socioeconomic challenges they are just facing. And they may feel difficult to pay for medications and other treatments, so that it is one of the contributing factors. So despite extensive global research, no study has specifically examined the prevalence of this PD in the Western Ethiopia, as well as we are unaware of the factors predicting or determining this in the this population. So this research addresses the critical gap by assessing psychological distress prevalence, and will report some associated factors, including the social support factor. So the objective was to assess the prevalence, and as well as to determine some demographic, clinical, and psychosocial factors among this population. So to answer this objective, just we applied a cross-sectional study. And the study was conducted in 2 major hospitals in the Western Ethiopia, which includes the Naqamte Comprehensive Specialized Hospital, as well as the Wallagga University Comprehensive Specialized Hospital. So we collected an actual data between February and March of 2020, and a population aged 80 and above, as well as those receiving or following their medical treatment in these hospitals were included as inclusion criteria. So through this, 427 participants were recruited or selected to take study, and we applied a systematic sampling technique to select the study participants while they attend the hospital. So the dependent variable was the psychological distress, which was measured by validated Kessler 6, which is a 6-item tool. And also the independent variables include socio-demographic characteristics, as well as the disease-specific characteristics, social support, which was measured by Oslo Social Support Scale 3, and the analysis was conducted, just descriptive study, just to obtain the frequencies, the mean, and other descriptive or analysis. Bivariate and the multivariate logistic regression was performed to identify the factors. So when we come to the results, so the current study demonstrated the prevalence of psychological distress among this population was 43.6, with an interval between 39 to 48. So this finding is just consistent, higher than the study conducted in Netherlands, Saudi Arabia, Malawi, Nigeria, and Uganda. And this is considerable or comparable with study from Kenya, and slightly lower than study conducted in China, in Gondor, in our country, as well as Sidama region of Ethiopia. And this discrepancy might be results due to difference in geographical, demographic, as well as clinical features, healthcare access, and the cultural reviews of psychological symptoms, as well as there is a variation in study design and sampling method applied. So this is a graphical representation just to show you the comparison between the global and the current finding. So the study is just, our finding is about 43.6. So different countries, Uganda, Malawi, Saudi Arabia, and Netherlands, including Nigeria as well. And the current study is there, and Kenya is comparable, and Sidama, China, and Gondor are slightly higher than the greater distress than the men when we compare gender variation. And the single married are more likely to develop PD when we compare with married, and the participants with limited or moderate social support were significantly more likely to experience psychological distress when compared with strong social support. So from this finding, just we can point out that older adults may encounter the compounded vulnerabilities, including a greater prevalence of diabetes-related complications, declining functional ability, and diminished coping skills might be related with that. And the finding, mostly with the movement, is collaborating with other studies done in Saudi Arabia. Women are more vulnerable to mental health challenges due to the biological, social, and the cultural factors, including their responsibilities as caregiver and hormonal influences heightened social expectations. All right. So this related to the marital status. Of course, single are more likely to develop the distress compared with those married. So this study is consistent with the study done in China. So the absence of spouse support. Of course, most of the social support is obtained from the spouse. So this may actually exacerbate feeling of loneliness, increasing of the burden of self-care, as well as limit access to emotional and instrumental support and other support that could be obtained from the spouse. And another one is regarding to the social support. Of course, individuals with limited or moderate are more likely to develop distress, and this could be due to the buffering of role of social support in the mitigating the emotional challenges in the chronic illness or diseases. All right. So the presence of comorbidity is another factor that could be affect. So this can be exacerbate the complication related to the mental health conditions, in addition to other factors. So in conclusion, nearly half of the adults, of course, 43.6 of people living with diabetes have psychological distress. Being female, older age, being single, comorbidities, being overweight, and low social support are associated with psychological distress. So the implication from this study is psychological distress is a silent wound. As I have said earlier, it is invisible wound, and it is silent that can affect many individuals living with diabetes. So it needs attention among caregivers, focusing on the identified factors. And implementing routine psychological distress screening, mostly for high-risk groups, older adults, women, single individuals, and those with multiple comorbidities is mandatory. Integrating mental health assessment into standard diabetes care support might be important to early diagnose this condition. So promotion of sustainable social and family support should be considered a critical component in the effort to reduce psychological distress within the diabetes. So future studies should adopt longitudinal study, and probably need to apply experimental studies just in order to show the causal relationship in a strong relation, and applying diabetes specific distress scale can help or improve the finding. So I'm sorry. So those are some references. So we thank study participants, Welaga University, for funding this research administration of 2 hospitals, for permitting data collection and to conduct study. Thank you very much.
Thank you, Dr. Garaje, for finishing exactly on time. So the next presenter, according to my schedule, the second presenter is Mr. Fayyaa Atomsa. He is going to present his research finding on magnitude of suicidal ideation, attempt, and associated factors among human immunovirus positive patients who are receiving ART at public health facility in Ambo town. So I'm called upon Mr. Fayyaa Atomsa to present his research finding, and I'm going to tell you his short biography. If Mr. Fayyaa Atomsa is currently working or affiliated at Ilfata Warada Health Office. He is working as Warada Disease Prevention and Control Coordinator. By training, he received his BSc in Psychiatry Nursing from Oromiyaa University and his Master of Public Health in Epidemiology from Ambo University. This is his short biography. Please, would you come to the stage? Thank you. You have 15 minutes.
Okay, thank you very much. My name is Fayyaa from Oromiyaa region, West Shawa Zone, Ilfata Warada Health Office, and I'm going to present on the title, which is a magnitude of suicidal ideation, attempt, and its associated factors among HIV/AIDS patients, those attending ART at public health facility in Ambo Town 2022. And when we come to the outline of my presentation, it includes this introduction, objective, methods and the materials, result, discussion, conclusion and the recommendation, and also acknowledgement. To begin with introduction, as introduction, suicide is one of the global public health concern and significant public health problem, which is resulting in 1 million deaths per year. And suicidal ideation in definition, it is defined as having a suicidal thought or desire. And suicidal attempt is a deliberate and unsuccessful attempt to end one alive. This both suicidal attempt and suicidal behavior is more common among HIV/AIDS patients than in general population. However, to the best of my knowledge, there was a little information about these issues in Ethiopia, particularly in my study area. Therefore, determining the magnitude of suicidal behavior and its associated factor among people living with HIV/AIDS is needed. Saying the introduction, this, when we come to the objective, as a general objective, it is to determine the magnitude of suicidal ideation, attempt, and its associated factors, and specifically to determine the magnitude of suicidal ideation, and to determine the magnitude of suicidal attempt, and also to identify associated factors separately with suicidal ideation and suicidal attempts. Coming to the methodology one, this study is conducted at Ambo Town public health facilities from September 1 to October 1, 2022. Study design is facility-based cross-sectional study design was conducted, and study population is all patients whose age is greater than 18 years old and attending ART clinic at Ambo Town public health facility during the data collection where my study population, and sample size was determined using EPINFO software, and it was about 401 sample size. During sample size calculation, sample size was calculated for all objective, and the highest sample size was taken, which is around 401. And sampling technique is consecutive sampling technique was used to select my study design during that, and data collection tools and the procedure, structured questionnaire, which is specifically for my outcome variable, WHO initiative version 3 composite international diagnostic interview scale was used to assess suicidal ideation and suicidal attempt, and it was face-to-face interview was conducted to collect the data during that. Data processing and the process and analysis, data is already entered into AP data version 4.6 and exported to spaces for analysis. After that, to identify the associated factor to both outcome variable, I mean to ideation and attempt, bivariate and multivariate logistic regression was used. And all variables in bivariate logistic regression were with a p-value below 0.25 were candidated for multivariate logistic regression, and all variables with p-value under the multivariate logistic regression, p-value less than 0.05 or significantly declared to the associated factor or outcome variables. Coming to the result, this is a social demographic one. Totally about 394 participants were fully participated by making 98.3 response rates, and the mean age of the respondent is around 34.8, and totally around about 51.8% of the respondents were female, and 34.3 of at college and above educational level. And coming to the first objective, which is a magnitude of suicidal ideation and attempt, from the participants, around 29.7% of the respondents had history of suicidal ideation under this 95 confidence interval, and around 14.2% of the respondents had history of suicidal attempt. And this magnitude of suicidal ideation in this study is found to be higher than a study conducted in Northern Shawa. The possible reason for this discrepancy may be early initiation of the drug therapy, healthcare accessibility in relation to time, magnitude of advanced stage of HIV can be the possible reason for this. And magnitude of this suicidal attempt, which is around 14.2%, is higher than study conducted in Dase, Ethiopia, which is around 3.3. The possible reason may be a lack of healthcare accessibility and the magnitude of advanced HIV. And when we come to associated factors, after conducting multivariate analysis, around these variables, around 6 variables were significantly associated to suicidal ideation at p-value less than 0.05. It looks this presence of opportunistic infection, HIV clinical stage, particularly HIV clinical stage 3 and stage 4, comorbid anxiety, comorbid depression, and family mental illness and social support were poor social supports, particularly were factors associated to the suicidal ideation. When we see this interpretation, it looks this. Participant who had opportunistic infection is 6.5 times more likely to have suicidal ideation compared to those who had no suicidal ideation. This may be due to having additional disease and too emaciated, which results in hopelessness and leads to the suicidal ideation. When we see depression as interpretation, depression, those participants or having depression is around 2.9 times more likely to think suicide compared to those who have no depression. This may be due to a neurotransmitter disruption, particularly scientifically it is known that those depressed people have a disruption in serotonin, which leads to hopelessness and leads to suicide. And also, as we try to see earlier, poor social support is also significantly associated to suicidal ideation. 3 times more likely to have suicidal ideation compared to with a strong social support. This may be due to patients with poor social support may feel hopeless, guilty feeling, and all helplessness, which leads to suicidal ideation. Coming to this also, HIV stage, WHO HIV clinical stage 4 is around 5.7 times more likely to think suicide than stage 1. And also stage 3 is 2.7 times more likely to think suicide compared to stage 1, those with stage 1 HIV clinical stage. The possible reason can be this one. Coming to the ideation, coming to the factor associated with suicidal attempt, around these 4 variables were identified after multivariate logistic regression is conducted. These 4 variables were identified as significantly associated with suicidal attempt, which is poor social supports. Poor social support is already, it is associated to suicidal ideation, plus it can be associated to suicidal attempts. Comorbid depression, presence of opportunistic infection, and family history of the mental illness were significantly associated to suicidal attempts. And when we see it is interpretation, having depression is 2.2 times more likely to attempt suicide than those who have no depression. This could be due to depressed people may have a low level of serotonin, which leads to suicidal attempts. And having family history of mental illness is 4.8 times more likely to attempt suicide than those who have no suicide family history of mental illness. This could be a genetic predisposing. Saying this about factor associated to the suicidal ideation and suicidal attempt, when we come to the conclusion and the recommendation, as a conclusion, the magnitude and the risk factors of suicidal ideation and attempts among HIV positive patients were remaining high. And early screening, addressing, identifying suicidal risk factor are essential to reduce the consequence of suicidal behaviors among people living with HIV infections. Coming to the acknowledgement parties, I would like to acknowledge my study participant while I'm conducting my researches. And also I would like to acknowledge particularly Oromiyaa Regional Health Bureau for inviting me for this event. And also I would like to acknowledge all who supported me by multi-direction. And also I would like to acknowledge all my audiences. This is all about what I have. Thank you. Thank you very much.
Okay, thank you, Mr. Fayyaa, for nice presentation, coming with the topic that is very important in the related with mental health. Now, the next presenter will be Dr. Gary Hunduma. He is from Oromiyaa University. By training, he has BSc Nursing from Oromiyaa University. He also had Master's MSc in Integrated Clinical and Community Mental Health from University of Gondar. And the recent, he has also PhD in Public Health from the same university, Oromiyaa University. And he is currently Assistant Professor of Mental Health at Oromiyaa University. And also is currently working as Associate Director of School of Postgraduate Study at College of Health and Medical Science, Oromiyaa University. He also published around 15 articles on high impact journals. And Dr. Gary will present on the title Mental Health Problem Among in School Adolescent in Harari region state, Eastern Ethiopia. So, Dr. Gary, where are you? Okay, the stage is yours. Thank you very much.
Okay. Thank you, Mr. Chairperson. Yeah. Good afternoon, all. Okay. This is my title, which says Mental Health Problem Among School Adolescents in Harari Regional State, Eastern Ethiopia. So, these are the presentation outline as usual. So, adolescent mental health problem is defined as emotional and behavioral problems, which may be classified as internalizing or externalizing problems. And this problem is globally, it affects about 14% of adolescents nowadays. And every year, about 46,000 adolescents are commit suicide. This is directly associated with depression or other mental health problems. And also about 75% of mental health problem is started before age 24. And in Ethiopia, this problem is accounted about 17 to 23%, but there is no adolescent-related or adolescent-specific studies in Ethiopia till now. So, according to some reports of WHO, it says the biggest unresolved health issues in Ethiopia is adolescent mental health problem, which needs issues. So what are the targets nowadays? According to the Sustainable Development Goal Target 3.4, this calls for the reducing non-communicable disease related to premature mortality by 1/3 by 2030. This may be achieved through working on mental health and other non-communicable diseases. So in line with this, Ethiopia also, as this morning, also talking on this topic, Ethiopia developed some strategies which works on mental health, including the adolescents. For instance, the National Mental Health Strategic Plan 2 is now developed and on work, which targeted by 2025, treatment coverage of the child and adolescent mental health should be increased from 1% to 20%. Now it is very ignored, and decrease the suicidal days per 100,000 from 11.38 to 10.57. But so far, no evidences are about this implementation nowadays. Now we are in 2025, and even no indicators are very specifically indicated in this document about the indicator of adolescent mental health. So these are some gaps. And also, social capital is one of the social determinants which is important and useful, which may be defined as the sum of resources that individuals and the communities access through their social networks, and the family, neighborhood, peer, and the school social capitals have been associated with mental health of adolescents. But these are not again stated in our country or in Ethiopia. And so, as significancy, this data may be the data for policymakers. It can designing, planning, and implementing targeted intervention. They can use the result from this one. It may benefit adolescents, families, and the communities by informing clinical and counseling guidelines, and also to acknowledge to literature or add some knowledge to literature and ignite future research in this field. These are the objectives. I do have 3 objectives. The first one is to determine the magnitude of mental health problem, and it is socio-demographic relationship or association, to examine the association between social capital and the mental health problems, and to investigate the association between mental health problems and health-related quality of life. These are the objectives. So the study was conducted in Eastern Ethiopia, in Harari Regional Estate, which is the city or the region has 6 urban and 3 rural administrative districts, and about 52.4% of the population in Harari region is urban dwellers or urban livers. And during the data collection, there are about 85 eligible schools for these studies, and we conducted from this data from November to December 2020. So a sampling procedure, a multi-stage sampling technique was used to select the schools first. And the schools are certified based on their location and the ownership, because there are public schools and non-governmental schools. So accordingly, about 23 schools and 133 sections were randomly selected. And finally, we reached about 3,326 adolescents from school and involved in this analysis. When we see the data collection, so we used structured, standardized tools to collect the data, and about 8 health professionals are included in the data collection. And the data quality control was performed through field manuals, questionnaire translation, training, question pre-test, close supervision, data editor also were assigned, and the double entry for validation of the data. These are what we use to control the quality of the data. So, when we see the variables we measured, the first one is mental health problem, which is used as outcome variable. And we used SDQ25 to measure this problem. And the second one is social capital, which is also measured by social capital questionnaire for adolescents. And the third one is the quality of life. And we measure this by using Kid Screen 10, which is the modified and validated tool from the Kid Screen 27 for adolescents. So when we see the processing of the data or data analysis, so the data is entered by AP data 3.1, and the multivariable ordinal logistic regression was applied to analyze the data. And the all model checking and the model fitness was checked, and the multicollinearity, all issues are assessed. Ethical approval, we taken ethical approval from Oromiyaa University College of Health and Medical Science, and goes through that one. So, the first one is, this is the magnitude of the mental health problem. So, we assess the overall or total difficulty of the adolescent mental health, which is about 22.9. And we also categorize them into internalizing and externalizing one. So the internalizing is 24.17 and the externalized one is 11.93%. When we see the association between the socio-demographic variables and these mental health problems, so rural residencies, marital status, public school attendance, and family occupation are significantly associated with this problem. So, being a rural adolescent comes from rural areas, the probability of having high mental health problem score is about 1.63%, higher than the other. And this may be because of burden of the socio-demographic issues, poverty issues, psychological adversities in the rural areas. The substance is also common in around Harare, and some may be because of parenting styles and so on. The second one is being in public school is also the probability of having a high score of mental health problem is about 1.44 times higher in public school adolescents, and this is also associated with some socio-demographic issues. Being married, which may be controversial with other studies, is also seen as a risk in this study. So being married at this age increases the probability of mental health problem about 1.41%. And this may be because of the psychological effects of matured marriage stage or higher risk of intimate partner violences and the lack of knowledge about the family planning and so on. This can lead to the problem. Okay, sorry, this is... Anyhow, this one is the association between social capital and the mental health problem. So about three components of mental health problem is, I changed this slide, anyhow, you can see that one. About three components of adolescent mental health problem is associated with mental health problems. So having networks at the school, having good social cohesion at neighborhoods, having trust at neighborhoods, it decreases the mental health problem according to this study. So these are the discussion, but they didn't correct my slide. So the other one is about the quality of life. So in this study, the quality of life, about 23% of adolescents experience lowest quality of life. So the quality of life of adolescents is highly affected according to this study. And mental health problems, categories of abnormal state of mental health problem is about 48% associated with the quality of life. And also it affects the functioning in multiple ways, because mental health problem affects the quality of life in multiple ways, including psychological, emotional, and physical disabilities. And also rejected by their peers. Those have symptoms of mental health, maybe that's the reason. So, conclusion, more than 1 in 5 in school adolescents experienced either internalizing or externalizing mental health problems, and the high social capital was associated with decreased mental health problems score among the adolescents. 1/4 of the in-school adolescents have a poor health-related quality of life, and the high score of mental health problem is associated with decreased health-related quality of life. When we see the implication and recommendation, so promote social capital as an intervention targeted in and incorporate into mental health promotion and the prevention strategy is very important according to these studies. Promoting and strengthening a school-based mental health program and service is essential. So tailored intervention is required for male students, rural residents, public health attendants, and married adolescents. Encourage students to participate in extracurricular activities as increasing the social capital, like join social clubs and communicate with friends and classmates to build student networks, and the trusts are very important. And a longitudinal study may be necessary to avoid the potential reverse causality of the social capital and the mental health problems. Include out of school adolescents with multiple informants to support the generalizability of and the validity of the finding is also important. This is cross-sectional, and it includes only in school adolescents. Mixed method like qualitative study is also important to validate the. So these are the acknowledgement. I would like to acknowledge Oromiyaa University for that supporting this study. Harare Regional Education Office who facilitate all the work in the region. School teachers of each schools, participants, data collectors, and these conference organizers, including the Oromiyaa Health Bureau. I would like to acknowledge them. Thank you very much. Sorry for my slide is not.
Thank you, Dr. Gari, for the nice presentation on mental problem in school adolescents. Thank you very much again. I'm not sure whether the fourth presenter is there or not. He's not there. Okay, so please, the presenters, three of you, can you come front? I will leave this position for you. So the time is for discussion. Discussion, which is maybe including questioning and answering. So when you're asking the question, please direct to whom you are going to asking the question. So Dr. Gari, yeah, Dr. Daraje, and Fayyaa. So they can use this one, yeah? Can I So I will give a chance to the audience. Who want to ask question, raise your hand. I will give the number. I can't see any hand right now. Any question? Appreciation? Okay. And Lakofsa Tokko, Gambra. It's a very sensitive topic. It's raised here, so you can ask question. Okay. Could you come to here? Thank you. Go ahead.
Okay. Thank you all the presenters for the nice presentation. It was a good presentation. I have some questions for Dr. Daraje. You said that psychological distress is high. The prevalence is about 43%. So does that specifically includes all the distress, depression, anxiety, or do you have separately measured this? That is one question. And what is your recommendation for this high prevalence? The other is for Fayyaa. I think if I am not mistaken, you said that suicidal attempt is higher than some place, specifically North Shore, and the reason you mentioned is early initiation of therapy. How is that possible? If you give me clarification. Thank you.
Okay, thank you. Any other question? Any other question, appreciation? No? So let me give chance to the presenter to respond directly to the question.
Okay, thank you very much for your question. So regarding the first question, does psychological distress include depression and other mental health conditions? Of course, while we measure this outcome, we applied psychological distress scale, which assess the components like feeling nervous, hopelessness, restless, and worthless, and the like. So depression is not inside. So we particularly assessed depression. So what is your recommendation? Because as I've concluded that nearly half of people living with diabetes are just experiencing psychological distress. So it is very important just to include the psychological distress measures while they actually visit for monthly checkup, because individuals with diabetes just visit their doctors every month, if it is not possible, every 2 months. So during this time, like they assess for other complications, it is commendable to assess psychological and other mental health as one of the complications. So as I have tried to narrate the finding from 126 articles, which was published recently by International Diabetes Federation on Atlas, it says that dementia, distress, vascular dementia are actually prominent among individuals living for greater than 10 years with diabetes life. So for mostly individuals who living with diabetes for a long period of time, it is very mandatory to assess and then intervene them for mental health, including distress. So this is my suggestion, but further research is very warranted just to show the causal relationship and to explore more about mental health among people living with diabetes and other chronic illnesses. Thank you very much.
Tole maqaan kiyya akka carraa namni na waamu Dr. Sheetuunfaa sirrii waamne fullaan jedhama, fulaa miti. Namni hunduu akka baruufi fullaan jedhama. Saying this, let me answer for the question raised by my colleagues. The suicidal attempt or magnitude of suicidal attempt is higher than a study conducted in North Ethiopia, that's it, which is 3.3. Mine is around 14.2. The possible reason for this highest magnitude of suicidal attempt can be early initiation of therapy. The reason why I said is that my study participants, ART patients, if they are not early initiated to the therapy, they may become deteriorated. This deterioration may lead to hopelessness and another mental health problem. After that, they may take suicidal attempt as a solution. Because of that, if they are not really initiated to the therapy, they may lead to suicidal attempt. I think the question is this. If there is no another question, that is the answer. Thank you.
Okay, thank you. I think we don't have any other question, even though we have a time for discussion. So I'm going to wrap up this presentation. Thank you, presenter. Please, can you join me to applaud them for their nice presentation? Thank you very much for your attention. The very important study population is touched here under the presentation. The diabetic patient, the HIV patient, and in school adolescents, they are the targeted population who are at risk for mental health. So thank you, the presenter, for coming with this, our segment of our population. Thank you very much. This is the end.
Galatoma, Dr. Isheetuudhaan guddaa galateeffannaa. I think sa'aatii boqonnaa 5 waan ta'eef boqonnaa 5 daqiiqaa 15 fayyadamne asitti deebina.
has a lot of experience and he has also authored and co-authored over 40 publications in different thematic area. He has also he has 4 award grants from University of Gondar in joint with European Initiative, and he has a clinical experience and worked in some district of Amhara Health centers. So for now, he will present on the topic of exploring the lived experience and coping strategy of mental health coverage caregiver in Ethiopia, implication for supportive intervention. Welcome, Shaggai. You will have 15-minute presentation. Stick on time. Good luck.
Thank you for the Oromiyaa Regional Health Bureau and the scientific committees to invite to present my work in this respected event. So my title is Exploring the Lived Experience and Coping Strategies of Caregivers in Gondar, Ethiopia. It is an implication for supportive intervention. So this is an outline, the presentation outline. So giving care for people with mental illness is a stressful event. So an individual has to be resilient to cope with this stress. So coping is a conscious efforts to manage, adapt to stress, adversity and challenge situations that exceed the individual's immediate resource. So caregiving creates a substantial physical, emotional, financial, exposing caregivers to high levels of burden, chronic stress and burnout. Caregiver coping strategies directly influences both patient outcomes and the caregivers as well. So research reveals that significant cultural and contextual differences in coping strategy utilization across population. There are determinant factors which has an effect on coping strategy. Some are the socio-demographic variables and the patient behavior, the caregiver burden, the physical health status, the social support availability, and exposure to disruptive behaviors of the patient. It has an impact on maladaptive coping. So the impacts of maladaptive has a physical health deterioration, quality of care decline, and there is, even though it has its own impact, there is some gaps. Despite the significant challenge faced by family caregivers, there remains gaps in understanding the coping strategy, knowledge gaps, and some methodological gaps, particularly in using some advanced models. So this is a conceptual framework. There are different factors, the socio-demographic, psychosocial factors, and the clinical variables that affect the coping, the adaptive and maladaptive coping. So the objectives of this study is to explore lived experiences, assess coping strategies, and its determinants among people with caregivers of people with mental illness as the University of Gondar Specialized Hospital, Northwest Ethiopia. The specific objectives were to assess coping strategy among family caregivers, identify determinants, explore lived experience of family caregivers. As a methodology, we were using the parallel mixed method or concurrent mixed method design, and it was conducted at University of Gondar Comprehensive Specialized Hospital between June and July among family caregivers during data, which were available during data collection period. And the sampling estimation was using the parameter estimation. That is using the observational with the parameter estimation. That was 10:1 with error term 30, covariance with 1 covariance and 28 pass coefficients and 55 non-response rate, which was 620 sample size. A systematic random sampling with k intervals of 2 was used, and pervasive sampling to the qualitative study was employed. The variable was dependent variable, which was adaptive and maladaptive comping, which was treated as continuous, and independent variable were the socio-demographics, the clinical variables, and other observed endogenous variables. There were variables that was measured using a standard tool. Brief COP was used for measuring the coping strategy. Also, social support was used to measure social support. Rosenberg self-esteem was used to measure self-esteem of the caregivers. The Kessler-10 was used to measure study participants' psychological distress. Perceived stigma and discrimination and evaluation was used to measure stigma, and in-depth interview was used to collect data for qualitative data. This was the measurement fit indices for the measurement model, for particularly for the outcome variables, the adaptive and maladaptive, and all the measures were in the recommended or in the accepted ranges, and also the model validity was also in the accepted ranges. When I come to the results and discussion, meal adaptive coping was 34.65 with 95 confidence interval of 34 to 35.28, which was higher than 25 study conducted in Ethiopia and Saudi Arabia. I mean, Saudi Arabia was lower than Saudi Arabia. And this might be due to the population variations in Saudi. It was conducted in health professionals, and in the Ethiopian study was conducted among female study participants only, and the assessment tool was also different with different Likert measurements. Our qualitative study participants, this finding shows that caregivers use both coping strategy with religious coping, the most common adaptive method. There are factors that affect us directly, the coping, the indirect, and the total effect, meaning both the direct and indirect effect. So the direct effect was being female, older age participants, being farmer, stigma, long duration of illness has a direct effect with adaptive coping, whereas physical abuse, history of physical abuse by the patient to the caregiver were the indirect effect, and number of admission was both the direct and the indirect effect. For the maladaptive coping, the mean score was 21.1 with 22 confidence interval, which was higher than studies in Iran, and this study was might be due to high stress from frequent hospitalization and symptom relapse lead to maladaptive coping, like withdrawals and avoidance. It has factors which has a relation with maladaptive coping, particularly factors such as psychological distress has a relation with direct effect with maladaptive, being sex, being female, age, able to read and write, job loss because of caregiving, verbal and physical abuse, duration of illness, number of admission, and symptom relapse, recurrent history of hospitalization was having a direct effect with maladaptive coping. Burden and comorbid medical illness was indirect. This was the final model, which shows the relationship between the direct, indirect, and both total effects with maladaptive coping with the model with the accepted range of model fitness indices. The result of the qualitative study was there was experiences of the individual, particularly regarding to patient's behavior and illness, such as feeling of hopelessness, mental exhaustion, loss of personal purpose or work, safety concerns, violence and distraction, and also self-harm were experiences of related to the patient's behavior and illness. For example, one patient was reported that you will give up on yourself, became hopeless, despair. I often feel sad and say to be myself, I have no hope. And the other is the social exclusion, particularly from the community. And one study participant reported that people or community are touching your wound, but I said to myself, I have to be strong. And the other challenge was economical challenge, financial burdens, medication cost, transport cost, current tough cost of living were the other experiences of the caregivers. For example, one participant reported that I finished my property. I have gone as far as Wallo and other Shoa Robi to get a solution for my child health. And the other is the religious coping. There were experience of praying, religious rituals, trusts in faith. For example, one participant said, I pray to God and says, take care of me, calm my mind. The other is the avoidance and withdrawal, that is a maladaptive coping. I mean, the coping, yeah. Leaving their home and taking time off from work is the experience of the caregivers. For example, one caregiver reported that I will go out, I shut down the door of my house and go to the neighborhood. These are the factors which has a relation with adaptive coping. One is female. So why female? Female is, being a female is reducing adaptive coping by 0.1. This might be due to the experience of high levels of emotional distress, which might limit problem solving compared to males, which further complicating their ability to adapt to cope with challenges. Our study is supported with other study findings. For our qualitative study, findings shows that mothers and sisters reported experiencing strong emotional burden and greater direct caregiving involvement. The other is age, which is contrary to the previous study. Age reduces adaptive coping by 0.07. This might be related to decline in physical health, loss of social support and networks, increased life stressors in my study. And the other is perceived stigma, which is a counterintuitive finding, which increases adaptive coping. The other is number of admissions. Number of admission has indirect effects on adaptive coping with 0.01. So this physical abuse by their mental ill relatives have a negative effect. Adaptive coping, possibly due to its contribution to perceived stigma, leading to feel blamed, judged, devalued due to their circumstances. This finding is supported with previous finding. The other is with maladaptive coping. There are several factors, but I will rush to some important variables, particularly the psychological distress. So this psychological distress has a positive effect on maladaptive coping. Potential reason might be psychological due to the family members' illness and behavior may impair emotional regulation, problem solving abilities, further exacerbating maladaptive coping, which is similar with other findings. The other is burden. So the burden has a positive, the direct and indirect effects on maladaptive coping with 0.45. The other is the comorbid medical illness. So comorbid medical illness has increasing the maladaptive coping with 0.25. So this might be due to caregivers can lead to comorbid medical, can both positive and indirect effects, which has the added burdens of managing their own health alongside caregiving, which leads to emotional distress.
You have only 2 minutes.
Okay. The other is job loss. Job loss has a positive effect with maladaptive coping. The other is recurrent hospitalization of the patient, which has repeated hospitalization can exacerbate feeling of hopelessness, overwhelmed, making it harder to caregivers to utilize effective coping mechanisms. The other is social support, which is a very important variable which has to be just intervened. So it has a negative effect with maladaptive coping. So strong social support, it acts as protective factors by providing emotional and practical assistance, which enables caregivers to navigate challenges effectively. So as a conclusion, family caregivers were having low adaptive coping compared to the general population, and caregivers use both adaptive and maladaptive coping. Some socio-demographic variables and clinical variables of the patient were unaffected with adaptive coping. Comorbid medical illness, caregivers literacy level, and some socio-demographic variables also have an effect with maladaptive coping. Furthermore, caregivers' present psychological distress have direct and positive effects with maladaptive coping. So as implication or recommendation for healthcare professionals, provide psychosocial support or psychological support to caregivers, especially for those symptom labs and abuse, and address stigma in early stages of the illness to promote adaptive coping. For Ministry of Health, implement preventive mental health programs to strengthen caregivers' coping strategy. And for researchers, conduct longitudinal studies to examine how clinical factors influences the caregiver's mental health and coping over time. And also, sequential explanatory variable is very important to identify the cause for some variables such as stigma. These are my sample references. My acknowledgement goes to study participants, data collectors, University of Gondar to provide ethical approval, and Mr. Jigu Gabaye, thank you so much.
Thank you so much for your nice presentation, and finally you have used your time effectively. So the next presenter will be Ahmed Jamal, and I will introduce you Ahmed Jamal. Ahmed Jamal came from Molenchiti Hospital, and he has a BSc in nursing from Jimma University and Master of Public Health from Adama Comprehensive and Specialized Hospital. And he has clinical experience, more of clinical experience, and he has been working on quality assurance as a quality health officer. He has an award 5 times from Wolenchiti Hospital consecutively based on the best performance. So Ahmed will present drug adherence and associated factor among epileptic patients attending follow-up at selected East Shoa Zone Public Health Hospital. And welcome, Ahmed, for this presentation.
Thank you.
Okay, you will have 15 minutes. I will stick on time. Use your time effectively.
Okay, thank you. Galatoomaan jedha. Maqaan koo Ahmed Jabali. Ahmed Jabal Abbaayyalaan jedhama. Godina Jimmaa aanaa Limmuu Kannatittiin dhaladhe. Garuu amma immoo godina Shawaa Bahaa aanaa Boosat hospitaala Wolenchitii jedhamu irratti quality officerii ta'ee hojjechaa jira. Taayitilii koo haala kanaan isinii dhiyeessa jechuudha. drug adherence and its associated factor among epileptic patients. Specific objective to determine level of anti-epileptic medication adherence among epileptic patients and to identify factors associated with anti-epileptic medication adherence among those epileptic patients. Method. Institution-based cross-sectional study was conducted from February 2021 to August 2022. It was conducted in East Shua, selected public health hospital among General Bishoftu General Hospital in the Orange District Hospital. A total sample size was a total of 642 patients were included in the study using consecutive sampling technique, which is non-probability sampling method. Data were collected using structured interview, administered questionnaire, and the medical record reviews. Data was analyzed using SPSS, and the predictors are identified using logistic regression and the statistical significant declared at p-value less than 0.05. On discussion and on result in the discussion, level of adherence to anti-epileptic drug, those with good adherence was 46.7, which is in line the study conducted at Kenya, in line with study conducted in Kenya. Those are associated factors like experiencing seizure-related injury, 3.3 times higher with its counterpart, absence of comorbid illness, moderate social support, low perceived stress. The finding was lower than the study conducted like in Uganda, which is 79.5%, Debre Marcos 62.2%, Dila Ethiopia 61.69%, and Adama Medical College Hospital, which is 67.3%. Possible justification for variation: study period, scope of study, level of declaration of adherence. I was used, as I mentioned before, p-value less than 0.05. Maybe in other study area, they may use other declaration of p-value. The other one is conclusion. In conclusion, adherence to anti-epileptic drug in the study setting was suboptimal, with less than half of patients demonstrating good adherence, which is 46.7. And comparing to other study conducted in Ethiopia context, the finding of the current study was low. Rural residents, those are the associated factors. Rural resident, which was 0.26, experiencing injury, presence of comorbid illness, moderate social support, and a low perceived stress were the independent predictor of anti-epileptic medication adherence. The other one is implication are critical to improving adherence. Maybe healthcare providers should strengthening health education, psychosocial support, addressing disease-related patient stress, considering impact of comorbid condition. Furthermore, large-scale longitudinal study should be conducted to provide adequate evidence about the cause of effect relation between the predictor variable and the adherence. Those are references. And finally, I would like to acknowledge my advisors for their valuable guidance and support. My heartfelt gratitude also goes to Orange Hospital, my current organization, for providing me the opportunity to grow and contribute. I deeply appreciate the encouragement of my family, whose support has been invaluable throughout this journey. I deeply appreciate the encouragement of my, finally, I would like to extend my special thanks to Oromiyaa Regional Health Bureau for the opportunity to participate on this conference. Thank you.
Thank you, Ahmed. you have used your time effectively. So the next presenter, or the third presenter, is Ababa Ukesa. He started his BSc from Jimma University in Public Health, Masters again from Jimma University, and he is also a PhD candidate in epidemiology at Jimma University. He also works at Jimma University from Department of Biomedical Sciences. Ababa has clinical experience and research experience. He has more than 20 research publications, and the 15 research publication is on international journals. So you will have, as usual, 15 minutes for the presentation, and good luck. Use your time effectively.
Thank you, Mr. Moderator, for a nice introduction, and good afternoon, everyone. So I'm going to present on title already mentioned by moderators. I don't want to repeat, already stated earlier. So my presentation goes through those subtopics, which begin with introduction and end up with acknowledging some individual and organization contributing for success of this finding. So as introduction, currently cancer and cancer-related health issue is a pressing concern worldwide, with 20 million new cases and nearly 10 million deaths. This impact particularly worsening in the low and the middle income country due to the resource limiting situation. Accordingly, in sub-Saharan Africa, cancer is an emerging public health issue, with the new diagnosed cancer cases surpassed 800,000, and the deaths due to cancer is more than 500,000 in 2020. In our case, according to Globacan 2022, the new cases surpassed 18,000, and the deaths due to the cancer is nearly 55,000, and the 5-year prevalence is nearly 160,000. Actually, this might not show the true burden of cancer in our case, because different factor is there. One is this data is prepared from the single cancer registry, because we do have only one cancer registry in Ethiopia, Addis Ababa Cancer Registry. The other is our detection rate also under question. Those things may contribute. The burden is, I hope, more than this one. So the newly diagnosed cancer patient experienced different significant psychosocial interruption. This condition cause the contribute for treatment interruption, then finally or eventually lead to the contribute for poorer clinical outcomes. So early assessment of psychosocial vulnerability along with timely psychosocial intervention is play the important role to optimizing the treatment adherence, eventually to improve overall prognosis. However, due to the scarcity of the study, particularly in a resource-limiting setting, psychosocial status of the newly cancer diagnosed patient is still inadequately understood. Therefore, our study aimed to assess psychosocial vulnerability among newly diagnosed cancer patients through detecting or determining quality of life, as well as psychological distress among newly diagnosed cancer patients in Jimma University Medical Center. These methods study design to answer this research question. The cross-sectional study design was applied. Actually, this study is a prolonged, longitudinal study and a cohort, prospective cohort. But for the sake of answering this research question, the baseline data was sufficient. So we assess this psychosocial vulnerability from the baseline data. This study conducted to June to December 2024 in Jimma University Medical Center, Oncologic Department. Jimma University Medical Center has been launched Cancer Treatment Center since February 2022. At that time, the second cancer treatment center in our country, next to the Black Lawn. Eligibility criteria for this study, all newly diagnosed cancer patients by histopathologically confirmed adult cancer patient were involved in this study. Outcome variable assessment, we do have two outcomes. One is the quality of life, the other is psychological distress. To assess quality of life, we have used WHO quality of life tools. This tool comprises 26 items. From the 26 items, 24 items important to assess 4 domains. This domain, physical domain, for physical domain, 7 questions. For psychological domain, 6 questions. For social, 3, and the environmental, 8. 1 items for general quality of life. The other 1 items for health-related quality of life. The summation of those value would be the maximum is 130, the minimum is 26. To be the low quality of life, the score should be lay between 26 to 65, and to be high quality of life, the score should be lay between 95 to 130. And the other is psychological distress. To assess psychological distress, we have used NCCN distress thermometric score. This score is visual analog scale, which run from 0 to 10. The 0 indicates that no distress. The 10 indicates that extremely distressed. So the patient selects the number that best describing or reflecting their distress level status. After that, list the problem behind of that distress. So this psychological distress is classified as 2, which is using 4 cutoff point. If the patient is indicate 4 and above, that patient should have, the patient have moderate to severe distress. If the patient selects 0 to 4, the patient had low distress or mild distress. This is a pictorial representation which is show the data collection procedure framework. The data were collected face-to-face using data collection tool. This data collection tool comprises different parts, so, socio-demographic characteristic, behavioral characteristic, clinical characteristic, as well as WHO quality of life assessment tool, as well as NCC distress thermometry score. After interviewing, the patient select their own distress level. After that, we have assessed different parameters for the sake of assessing nutritional status of the patient, because we have used the GLIM criteria based diagnosis of malnutrition. The GLIM criteria needed different parameters. The one is anthropometric parameter. The other is body composition. This is BI to conduct, to assess body composition. Then it need laboratory finding, particularly CRP level is needed to assess nutritional status of the patient. So for that purpose, we have collected 5 ml of blood, then sent to the laboratory, then conducting laboratory assessment or analyze by using COBAS machine. Finally, analyze the data using our statistical software, and using binary logistic regression analyze to declare the statistical significance. We have used 95 confidence interval and p-value. Ethical, we obtained ethical clearance from Jimma University Institute of Health with this reference number, and the date approval was 26 May 2024, and verbal consent was obtained from all participants. When I come to the result, totally 231 patients is involved in this study. Among those, more than half of them lived in rural area, nearly 52% lived in the rural area. The mean age of those patients was 46 plus or minus 13 standard deviation, and more than 2/3 were female, nearly half of them were illiterate, and the 36.4 were farmer. This is a pictorial representation of 4 domains of quality of life, the mean score of quality of life. So as you can observe it, the minimum, minimum score obtained or observed under psychological domain, environmental domain, and followed by the physical domain. Overall quality of life, from 231, only 12 patients reported have high quality of life, and the distress level status, nearly 50%, 49.8 patients reported or experienced moderate to severe distress. According to the NCC guideline, those patients need psychological intervention as well as assessing further psychiatric assessment. But in our case, leave alone the intervention, assessment also not functionally implemented in cancer center. So these associated factor for both outcome variable like residency, body mass index, duration of illness, advanced cancer stage, and the distress thermometry score statistically significant with low quality of life. For instance, the residency, being patient is from the rural, nearly 5 times more likely to be low quality of life. This might be due to the rural patient faced healthcare infrastructure challenge because of maybe there is no access to diagnosing of cancer in the rural area. So the duration may be got with this prolonged time to be diagnosed. Then the other is duration of illness. As the duration of illness increased by 1 month, around 1.2 times more likely to be low quality of life. And the other is advanced cancer stage. Those patients diagnosed with advanced cancer stage, nearly 5 times more likely to be low quality of life, because when advanced cancer stage, the symptom is more complex. This condition may affect the physical activity of the patient. This condition contributing for low quality of life. The other is distress. Distress because one of the domain of the physical quality of life. This condition have positive effect in the low quality of life. The other is about the distress level, like advanced cancer stage, intent of treatment, and the nutritional status statically associated with distress level. For instance, in the case of intent treatment, those patients diagnosed with palliative care is nearly 0.3 times more likely to be moderate to severe distress. And for those undernourished patients, nearly 3 times more likely to be moderate to severe distress, because among the undernourished, those patients lack energy. This energy, when the patient lack energy, maybe the patient more distressed, and the symptom by itself can more suffering the patient. As conclusion, the finding of this study underscores the substantial burden of psychological distress and the low quality of life among newly diagnosed cancer patients with notable low score across psychological domain of quality of life. Nearly half of experience more moderate to severe distress with significant association with factors like nutritional status. Early detection is have a dual effect for sake of treating cancer by cell, and the other is to analyze or assessing psychosocial vulnerability is very important by preserving physical function, emotional well-being, and the social engagement, which is the key component of quality of life. This condition tailored to support for late stage palliative care, which is the both factor associated with both outcome variables with a low quality of life as well as psychological distress. Sorry. As implication, therefore, implication of this current study finding, high prevalence of psychological distress and low quality of life among newly diagnosed adult cancer patients underscore the urgent need for early identification of psychological vulnerability and the timely intervention. Therefore, need for psychosocial support. Those late stage palliative care, malnourished cancer patients benefit from the integrating mental health care with physical health care, as this population represent particularly vulnerable group. Policy and practice shift healthcare system should invest in a screening program for screening cancer as well as for screening psychosocial vulnerability of the patient, and early diagnosing campaigns and integration of psychosocial centered care with the physical health care to reduce psychosocial vulnerability. And further study may needed on the effectiveness of psychosocial centered care among those newly diagnosed cancer patients to address that condition. Thank you very much. I would like to thank some individuals and the organization. I would like to thank my advisors, Professor Lelisa, Professor Tafarra, and Dr. Mulala, and the Jimma University for sponsoring this, and as well as the cancer project, CDRM cancer project, for covering all expenses and body composition assessment, laboratory, and the data collection. Finally, I would like to thank Oromiyaa Health Bureau for inviting me to present this finding, and I thank you all.
Okay, thank you so much, Abebe Lukasa. Now we have a discussion time, so I call up all presenter here. Please, all presenter, Ahmed, Shagaye, and Abebe Lukasa, come here, and we'll have comment and questions. From participants, if there is any comment, question, and suggestion for these presenters. Anyone? Any suggestion, question, comment? Okay, thank you, Professor.
Okay, thank you very much. My question goes to Shagaya. Shagaya, thank you very much for your nice presentation and bringing an important topic, coping and its effect on health. Definitely, it is said that 10% of our life is what happens to us, and 90% is how we react to it. Our life depends on how we cope with stressor, and it is nice to understand stressors and teach people how to effectively cope with stressful situations. However, you dichotomized coping strategies into adaptive and maladaptive, and this may affect or misclassify some coping strategies because some coping strategies that are classified under either adaptive or maladaptive may have two components. For example, if you take emotional support as a coping strategy, depending on how the person seeks the emotional support, may be either adaptive or maladaptive. For example, if a person seeks social support from other persons and depends on other persons to solve his problem and becomes submissive, it may be maladaptive. If the person tries to get advice from other persons so that he uses the advice to solve his problem by his own, it becomes adaptive. And the same is true for religious coping. For example, some components of religious coping may be adaptive, others may be maladaptive. And the choice of a coping strategy depends on how the individual appraises the stressor through primary and secondary appraisal. So usually coping strategies are classified into three as problem-focused, emotion-focused, and dysfunctional in order to avoid misclassification. So how did you choose to dichotomize coping strategies into two, adaptive and maladaptive? And the other is coping strategies may vary according to stressors and individuals. Some individuals may use the same type of coping strategy across stressors. That is what we call dispositional coping. Others may change their coping strategies over time, depending on how they appraise the coping strategies. And that may be situational coping. So which type of coping did you measure? Is that situational coping or dispositional coping? So in terms of age and sex, who are likely to use adaptive coping, females or males. The same is true for maladaptive coping. The younger or the older people who are likely to use adaptive, who are likely to use maladaptive coping. Would you please explain in terms of age and sex? Thank you very much.
Okay, thank you, Professor.
Okay, thank you all for your nice presentation. So I would love some two questions to Mr. Ahmed. Of course, your title says drug adherence and associated factors among epileptic patients. One, I wonder on the finding which says moderate social support where or was positively associated with adherence. I doubt that strong social support might have good medical or medication adherence, but with strong adjusted odds ratio with 4.13, it says moderate social support. So how could you interpret this finding? The second one is, of course, we do have different tools to measure medication adherence. So which tool did you use to measure this? And it is very important that this is one of the chronic and longer-term follow-up is deemed for such patients. So did you consider the medication adherence among different chronic illnesses? For instance, hypertension is there, epilepsy is one of diabetes, and cancer. Of course, they need to have a long follow-up. So did you see, of course, even though it is out of your objective? Another one is your finding says it is suboptimal. So, of course, interpretation might have some difficulty to say. So what do you suggest just to improve beyond assessing the level of adherence? Another one is, I would have some questions, suggestion for Mr. Ababe. You used the WHO brief quality of life measure. You know that it is one of the broad. It is not disease specific. So did you find some validated, reliable tool to measure the quality of life specific to the cancer patients? Did you consider that? The second one is, of course, your outcome variable, as mentioned before, you dichotomized them. But even though we went to now, of course, to the copying strategy as maladaptive and adaptive, do we now the relationship between quality of life with directly with the copying level? So did you consider that factor? Okay, thank you very much.
Thank you, Dr. Daraje.
Okay, thank you all for nice presentation. Just have one clarity question. It goes to three of them. One of them can react if they need. I am very aware that in mental health or illnesses, there are a very numerous number of data collection tool which is highly standardized to the developed world. And in the three presentation, we haven't seen those data collection tool which is validated to Ethiopian context or tailored to Ethiopian context. And also the tool they used is a very general tool, not too specific to their study population like cancer patient, epileptic patient. There may be caregivers like quality of life. So do you think that using unvalidated data is merely misleading to the finding to concludes that there is a distress, there is maladaptive, there is low drug adherence, there is other findings that you are presented. So what do you think in the future to have a validated tool in Ethiopia for the mental health? Because data collection tool is very matter deepness. Thank you very much.
Anyone? Okay. I think for the interest of time, if there is no question or comments, let us begin from the first presenter, Mr. Shaggai.
Thank you, Professor, for your constructive comments and questions. Actually, for categorizing these 20 items of coping, as you said, there are different categories for as emotional, problem focused, and dysfunctional focused. But there are some literatures. My category is depending on previous studies. For example, Meyer and Ital categorized maladaptive and adaptive, and also he or she categorized these 20 items into adaptive and maladaptive. So that's why I were just using these literatures. But as you said, we try to show the effects of adaptive over the maladaptive, at the same time maladaptive over the adaptive using the non-recursive models. So at the end, there is one directional, meaning adaptive has an effect with maladaptive. So I was just considering like that one. The other is the caregiver situation. This is actually depending on the stressors, as you said. And these individuals are disturbed with behaviors of their ill family individuals, and it depends on the patient's behaviors, meaning it can be the situational, and sometimes can be the dispositional coping. So the situational is most likely considered. And the other is in terms of sex. Individuals with female were having low adaptive coping compared to males, and our qualitative study findings support these quantitative findings, in which females were reporting high exhaustions, responsibilities, and other activities, which along with other routine activities, which leads to the maladaptive coping, reduce their adaptive coping. The last is the assessment tool validation. Yes, this is very important and critical to say this is true, or to say this finding is true or not. So we have to follow the validated tool. For example, when I come to in my assessment tool, this tool was validated, tried with previous studies with different population actually, but we went just to go through with procedures to say this finding has an implication for a true result. For example, I did the pre-tests before the actual data collection, which has an implication for some amendments, and also we're checking the reliabilities or the consistency of the items for each participant's response, and also we were checking the items validity issue. For example, in my case, so it was in the accepted ranges. And this is for the future, it is very vital, and so we have to just adapt this tool validation. Thank you so much.
Okay, thank you. The question raised for me is how do you interpret the moderate social support. Why you don't compare with the strongest social support, I think. So I categorized into 3 parts: strong, moderate, and low social support. For comparison, I used moderate and present here, but for strong social support, I didn't bring here. For comparing with low, I used that moderate one. The other one, which tool used? I was used Morosky medication adherence scale, and I didn't see the other NCD like hypertension, diabetic, and others. I only did on antiepileptic medication. The other one is why it is suboptimal. The question raised for me is that it is not enough. Still, the many study is not conducted on this title, so it need further. I wanted to say it need further research on this title. And the other one about data collection tools, I was used adopted validated structure data.
Made kan barreesse kaleessa gara imperialist Itoophiyaa tabara maddii saglaffaa injifachuun isaa ni beekamaariif Naziif Jimmaa Manchuurraa kan barreesse waa'ee Manchester City wanti haaraa maaltu jira maamila keessan ta'uun barbaadeedhe maamila keenya taatee jirtan nuuf barreessisee Abbaa Jihaad Jimmaa Omoo Beyyemirraa Liverpool wal qabsiisee Liverpool jibbuu waa'ee kubbaa miilaa namni Liverpool jibbuu waa'ee kubbaa miilaa beeku jechuudhaan kan barreessee akkasumas immoo Tuujii Arabuu godina Bunnoo Beddelleerraa Aanaa Booracharraa kan barreesse waa'ee Arsenaal wanti haaraa maaltu jira jedhee Khalid godina Jimmaarraa innis waa'ee Arsenaal jedhee Ridwaan Taajuu Jimmaarraa kan barreesse Arsenaal wancaan isatti Arsenaal fi wancaan isatti wal beeku jechuudhaan kan barreesse akkasumas Kamal
quality of life as well as European Organization for Research Questionnaires. So for sake of my time, I didn't present here. Sorry for that. But we do have 3 tools. As you know, all tools have a drawback side as well as strong side. To see the variation between the tool, we have used 3 tools in our mega project. For this presentation, I didn't present it, but for that, I would like to apologize. The other is about coping strategy. About coping strategy, we didn't involve in our analysis, but I will do. For your information, this project is not the cross-sectional project, actually cross-sectional design, but prospective cohort, which we follow those newly diagnosed cancer patients for 1 year before the treatment, at the 50% of the treatment, and at the end of the treatment, and after 1 year of the diagnosis, we will see by 3 different dimensions of quality of life, as well as we assess multidimensional of the patient. For instance, the nutritional status of the patient. In the very beginning, I didn't present here, around 50% of the patient is malnourished before the initiation of the treatment. The treatment by itself can cause more malnutrition, more low quality of life, and the psychological distress. We will see the pattern of those factors. For that matter, we evaluate the patient in different tools. So this is what I do have.
Okay, thank you. I may have one issue of clarity. I think you have covered the face of Ethiopian patients in the display. Ahmad is you, and but not the foreign one. The white people face is not covered. So why? Is there any special issue?
We didn't obtain the consent. For that reason, I hide those patients. But what I've used in the white patient already Google access on the online. So for that matter, I didn't consider to hide is very important for those patients. Already we can find on the online. So for that reason.
Maybe that people may have the consent of displaying that photo. But we need to think over such kinds of issue. And thank you for your nice presentation, and thank you for active participation. I thank all of the presenter and have a seat. By this, I think we have finalized today's presentation. And thank you, Gich.
Thank you so much, all. So we will have a few notice for our tomorrow's session. We will start the session at 2:30 within this hall. The morning session will be the common session, which will be undertaken on with panel discussion on important issue for all participants. It consider mental health training, research, and the policy perspective in Ethiopia. So don't miss it. Come early, and you will get a lot of expertise on this area. So poster presenters, you should have to be at the side of your poster during the tea time, and there are facilitators to take attendance. So Glando Biomedical Solution also requests you to visit their products. They are on the corner of outside. Thank you so much. Nagangala Galatoma.